Good afternoon, everyone. Welcome to the instruction course on lasers, the past, present, and the future. We'll start with a short overview on lasing mediums and delivery systems and go on to the other types of lasers, both for medical retina and for tumors as well, and also look at some of the newer delivery systems that there are to deliver lasers for diabetic retinopathy. So evolution of lasing mediums, we'll cover the introduction, the history of properties and physics, the types of lasers, the tissue and laser interactions, the modes of delivery, mediums, safety, and the lenses used. So laser basically stands for light amplification by stimulated emission of radiation, and this was a term coined by Gordon Gould. Laser actually means to absorb energy of one form and to emit a new form of light energy, which is more useful for therapy. So laser, going back to the history, there was initially, though the concept was by Einstein, it was Maiman who was the first person to successfully build and operate a laser. 1960 was when it was first built, up till 83 when the Troquet developed the excimer laser. There's been a lot of developments. So as we know, how does laser light differ from ordinary light is that it's monochromatic, it's directional, and it's coherent. Hence we are able to actually target it to any particular point for the therapeutic reason that we're using it for. So there are different types of lasers: solid lasers, liquid, dye, semiconductor laser, and excimer. Some of them have been outdated in their use, and most of them are still being used in current practices for different reasons. So this is the electromagnetic spectrum in nanometers. You will see where the different types of lasers lie. So going on to tissue laser interaction, so it's either varies from the laser or because of the tissue reaction. As far as laser variables are wavelengths, the spot size, the power, and the duration, and as far as the tissue variability goes, it depends on the transparency, the pigment, and the water content. So these are the different ways the interactions can occur. They could be transmission, absorption, diffusion, or even reflection. So when you look at the thermal reactions, there's photocoagulation, vaporization, carbonization, and hyperthermia. With ionization, we use it for photodisruption, and photochemical is for photoradiation and photoablation, which is again each one of them used for the various therapeutic modalities. So once there is photocoagulation, the laser light reaches the target tissue, generates heat, denatures the proteins, leading on to coagulation. There's a rise in temperature of about 10 to 20 degrees Celsius, which will of course cause coagulation of the tissue. So you can see how the lasered tissue appears. Photoradiation is also known as PDT, and one of the other speakers will cover it in detail. This is a photochemical reaction that follows selective exposure to visible or infrared light after administration of an extragenous chromophore. Commonly used ones are hematoporphyrin and benzoporphyrin derivatives. Photoablation breaks the chemical bonds that holds the tissues together, essentially vaporizing the tissue. This is in the form of excimer laser. And photodisruption, its laser light goes on to optical breakdown, miniature lightning bolt happens, there's vapor, this quickly collapses, there's a thunderclap, acoustic shock down, and tissue damage. So this is the type that is used to open up the posterior capsule. So going on to the modes of operation of lasers, you have continuous, you have pulsed, Q switched, mode locked lasers, fundamental systems that are there, and multimodal systems. So each one of them are used for different types of lasers and deliveries. So going on to the delivery systems, you have transpupillary, which is slit lamp, and indirect ophthalmoscopy. In between, once the indirect ophthalmoscopy took over, slit lamp had come down, but now back to pattern lasers. We've gone back to slit lamp lasers more popularly. There's also transscleral, which has both contact and non-contact, photocoagulation, and endo laser. So going on to the delivery systems, right now slit lamp biomicroscopy is the most commonly employed mode. Advantages are it is binocular and stereoscopic, it has got a fixed distance, standardization of spot size is more accurate with this system, and aiming accuracy also is very good. Of course, the disadvantages are that it is a contact system, so sometimes you may have, the media may not be very clear after doing it, cannot be used on pediatric patients, and it's also not portable. Whereas the next one is the pattern scan laser, which again is built on a slit lamp. This is an integrated semi-automatic pattern scan laser photocoagulation system that is basically designed to treat ocular diseases using a single shot or a predetermined pattern array. The laser source is Nd:YAG, and the delivery device is a slit lamp or even laser indirect ophthalmoscope. Control system for selecting power and duration exists, and the method for selecting spot size as well. This also will be covered in detail in the course as it goes on. Navilas or navigated laser therapy is an integrated system that combines fundus photography, FA, FAF and infrared imaging, and a target locked frequency double YAG laser is used. So here basically the target is locked. It's designed for accurate treatment of leaking microaneurysms. This scanning slit lamp based system allows image overlay and laser stabilization on the retina using image processing in the treatment of retinal lesions. Eye tracking mechanisms also exist in the system, and this compensates for the ocular saccades. So going on to the LIO, the advantage has wider field, it has better visualization if in case the media is a little hazy, and also the ability to treat in the supine position, which is sometimes required not only in pediatric patients but for a few other conditions as well. The disadvantages are there is some difficulty in focusing, at least for a newcomer. There is difficulty in standardizing the spot size here. It's expensive, and uncooperative patients where you need to ask the patient to look in one particular direction, it may not really be easy, and there is a learning curve for this particular delivery system. So we have something called as a sub-threshold micropulse diode laser as well. Here the wavelength is 810. It is sub-threshold, targets only the RP melanocytes. It does not produce visible intraretinal burns or damage as well. Laser energy is dispensed in a burst or an envelope of micropulses, so it limits the time for heat conduction in the adjacent tissue, thereby reducing the collateral damage here. There is less light scatter, which permits treatment through even dense cataracts. The disadvantages here is because you cannot see the burn or the spot, you may actually be under-treating the patient. So these are the different lasing mediums. Argon laser, the advantages are it is coherent, monochromacity, and you can also get a smaller spot size. Disadvantage is that it can cause cataract because of absorption. In Nd:YAG, the advantage is it is well absorbed due to its double frequency by both hemoglobin and RP, but it can cause scattering and poor penetration through a dense cataract or a vitreous hemorrhage. With krypton laser, it could be used for the treatment of FAZ and papillomacular bundles because of absorption by xanthophyll, and it has a better penetration through cataract and to vitreous hemorrhages. But it is less effective in pale fundi because melanin is very important for it to act. PDT will be covered in detail. The dye dose here is 6 milligrams per meter squared body surface area, and an intravenous infusion of over 10 minutes is given, and the treatment at 15 minutes or after starting the dye is when the laser is given at a wavelength of 689, irradiance of about 600 milliwatts per centimeter squared. Transpupillary thermotherapy involves ultrasound, microwave or infrared radiation to deliver heat to the eye. Application of diode laser to the tumor surface in regions of disease activity is when this modality is used. Goal of this particular modality is to cause tumor cell death by raising the temperature of tumor cells to above 45 degrees Celsius for about a minute. Therefore, it reduces the blood supply and produces apoptosis. So these are some of the small choroidal malignant melanomas that have been successfully treated with TTT. So a couple of safety measures. The class 1s are the safe, they do not cause any biological damage, and up to class 3 where it is not safe even for momentary view, and class 4 can cause even severe damage. So some of the laser safety regulations are that patient safety should be ensured, making sure there is correct positioning. And you know how the amount of damage that it can cause. So if you're doing a PRP with very high burns, you should ensure that the macula is not targeted even by mistake. There's also the danger to the surgeon, and this is usually avoided by having a filter system. And if you're having a teaching system where you want to show your fellows or there's an observer, it's always good to give them protective glasses. So burn intensity is something that we also need to be aware since we're covering basics. So when light is a barely visible retinal blanching to heavy, which is a dense white retinal burn. So depending on what indication it is, the range of the laser burns will vary. So lenses, there are many advantages, disadvantages, the uses are several. I think this is available in any textbook. If anybody would like details, I'm happy to share the presentation. So I'd like to thank Dr. Nimesh, our fellows helped me make this.